Dr. Goswami?
Yes, I am sharing my screen now, sir.
Yeah, definitely. Yeah, please go ahead.
Hope it is visible.
Yes, sir.
I think it is not going to the main this thing. Can you see the screen?
Yes, we can see the screen. It's well seen. Yeah.
Yeah, sure. So, good afternoon, everyone. We come to the last day of the online module. And today I'm going to talk about neonatal EEG and infantile epileptic encephalopathies. So at the outset, I'm giving a disclaimer that we cannot cover everything about neonatal EEGs in a single talk. And things are quite different from EEG in a child. So I would be trying to give an overview about the basics of neonatal EEG, certain important terminologies which you have to be aware of, the peculiarities which are associated with neonatal EEG, and the maturation pattern of these EEG patterns, the EEG in a neonate. However, I won't be covering about CFM or about amplitude integrated EEG, which is nowadays a standard of care. I will be talking about conventional EEG mostly. And then I would go to the second part of the talk, which will be to touch upon certain epileptic encephalopathies. They will spill over to certain early childhood onset epileptic encephalopathies also. So this is one guideline paper which I would ask the junior residents here to download, because in case you are interested, this is the resource paper which has been used for developing EEGs in neonates and for reading EEGs in neonates. Neonatal seizures, we all know, are sudden paroxysmal change in neurologic function, and incidence is quite high, going up to 1 to 5 per 1,000 live births. And the peculiarities we are all aware of, which we are not covering here as it is theory mainly. But because of the excitatory action of GABA, there is more chance of having seizures in the neonatal age group. And the role of neonatal EEG is very, it is a standard of care. All neonates who are suspected to have seizures clinically should have a conventional EEG. And the ILA task force has spelled out that besides detection of seizure to differentiate from seizure from non-seizure, also to monitor encephalopathy progression, to prognosticate the outcome in cases such as HI, and to assess the severity of brain dysfunction, neonatal EEG is a must. The EEG requisition slip, while filling up the requisition slip, 2 points have to be kept in mind. One is the gestational age and the corrected age. This is very important. You will come to know why as the presentation progresses. As you all know, corrected age takes into account, it is not only the date, the number of days after birth, it also takes into account the actual gestational maturity. Desirable info includes birth history, any history suggestive of seizures, whether the neonate is being ventilated, it has undergone head cooling or things like that. And certain age specific features are there. Neonatal EEG is very dynamic because within days and weeks, the EEG patterns differ. Certain new changes appear and certain disappear. So if there is a persistence of particular finding in an EEG of a neonate beyond an expected time, then there is abnormality. Secondly, if a newborn has had some sort of insult, then the brain functions at a dysmature or an immature level. So certain abnormalities appear which should have disappeared by then. However, we have to keep in mind that wrong interpretation is very highly likely if the age is not given properly in the requisition slip. So how do we apply a neonatal montage? It stands to reason that the head size is small, so you cannot apply 21 leads. The newborn EEG normally can be reported with 8 to 12 leads, which are applied according to the 10-20 system. Up to 3 years, 12 to 16, and beyond 3 years, it depends on the head size. However, it goes up to 21 leads. However, if a child, for example, a 2-year-old has got severe microcephaly, his head is say only 36 centimeters, 37 centimeters, then he or she would also be subjected to a neonatal montage. Because if you put too many leads, then there will be no potential difference. There will be abnormal, there will be difficulty in reading the neonatal, reading the EEG. So as has been told already, when to obtain neonatal EEGs, whenever you think about a neonatal EEG, you do it. In the NICU, all high-risk neonates, at least within 48 hours of birth, should have an EEG. So there comes the role of continuous EEG monitoring, where the EEG is compressed in as far as time is concerned, and in case there is a doubt that there has been a seizure, that part can be expanded, or the neonate can be taken for a conventional EEG. In case there is seizures, in case there is encephalopathy which cannot be explained by anything else, and rather than a single EEG, series of EEGs, at least weekly or 2 weekly, for evaluation of the abnormality and for looking into the brain maturation. These are important factors in a neonatal EEG. This is different from a child's EEG. So now going to the terms. So a word which you will hear very commonly in neonatal EEG is continuity, continuous and discontinuous. So what is this continuous EEG? So continuous EEG is basically a record which when you see without using any gadget, just a visual impression, the amplitude throughout the EEG record is more or less similar. The waves have non-stop electrical activity with at least less than 2 seconds of voltage attenuation. This is a term which you may not remember as far as initial practice is concerned. So this is an EEG record where the amplitude throughout the record is more or less similar. Discontinuous EEG is what normally we talk about as burst attenuation or burst suppression or things like that, where you have certain high amplitude waves followed by area which is suppressed. So these high amplitude activities are known as bursts, and the low amplitude intervening period is known as interburst interval or IBI. This is a very complicated looking slide, but it has been taken from standard neonatology textbook, where just remember that these terms, trace alternance, trace discontinue, and burst suppression, these refer to periods of discontinuity in the neonatal EEG, and it is an evolution, and I'll show in the next slides how it evolves. So this record is known as a trace discontinue. So trace discontinue, what happens is a part of the record has got bursts followed by attenuation, and the difference between trace discontinue and trace alternance is the amplitude of the intervening period. Intervening period is the interburst interval, and there are certain these areas, these bursts have got certain characteristics. It looks spiky. There are waves here, as you can see. So in case a neonatal EEG has got very low amplitude, you would have to change the sensitivity in order to amplify the waves. So just keep it in mind that trace discontinue and trace alternance are periods of discontinuity which subsequently can be are as the neonate matures, they disappear, they go down, and beyond 38 weeks one does not see discontinue. Preterms trace discontinue is quite prevalent, whether the baby is sleeping or awake. However, trace alternance, that comes after 34 to 36 weeks of postmenstrual age, and it is not to be seen in a normal healthy brain beyond 46 weeks. And These happen because there is an increase in excitatory synapses, there is decrease in the subcortical inhibitory activity. So as had been told already, the EEG in a newborn is very dynamic. Burst suppression is an abnormal EEG at whatever age it is. So here, this part, which is the interburst interval, has got voltage less than 5 microvolts. Whether in trace discontinue, it is less than 25, and trace alternance, it is bigger, it is higher, that is around more than 25 but less than 50 microvolts. So just to make things simple, I am spending more time on these slides because this is an important concept, that the progression of maturity passes from discontinued to alternance and then to a continuous sleep record. This is a sort of a continuous sleep record where the amplitude, though there are bursts, there are there are waves which are appearing bigger and these are appearing smaller, but more or less they are continuing in the same range. So can anyone comment on the EEG shown here? I'll just give 2 seconds if anyone would like to comment. Okay, so there these bursts are appearing. They, if you see the entire record, they appear for 1 to 2 seconds. But interburst interval is very, very low amplitude and there is no reactivity also. It is more or less like a straight line. This is a burst suppression pattern. The next term which I would like to talk about is symmetry. Symmetry, as far as an EEG is concerned, and had been told earlier in child's EEG as well as in a neonatal EEG, is activity on homologous region of both hemispheres. For example, right occipital, left occipital, O1, O2, right temporal, left temporal. So they should look more or less mirror images as far as the amplitude is concerned. Little bit of asymmetry is acceptable. However, if the asymmetry persists throughout in a 2:1 ratio, for example, the amplitude in the left is say 100 microvolts, amplitude on the right is 200 microvolts or 150 microvolts throughout the record, then it is diagnostically relevant. You have to find out why it is happening. So this is an asymmetric record which has been flashed here. Here, if you just focus on O2, unfortunately, I don't have the scale here. Here, if you have focus on the O2 and the O1, there is a symmetry, there is an amplitude difference. These waves are 50% bigger than these waves, and it continues throughout. The baby had a collection of blood in the occipit of the area which has been shown as basically on the left. Then comes the term synchrony. So the third term which I would like to emphasize is the difference between synchrony and asynchrony. Synchrony refers to the waveform, the onset of the burst of activity. For example, if a negative waves to refresh goes up and positive goes down as far as an EEG is concerned. If they occur more or less simultaneously with a difference of maximum 2 seconds of a particular waveform, then it is synchronous. However, synchronicity is quite accepted norm in a child's EEG, but not so in a neonatal EEG. Up to 30 weeks, it is hypersynchronous. Both the sides of both the hemispheres fire simultaneously. But from 30 to 36 it becomes highly asynchronous, and beyond 36 again it becomes synchronous. This happens because of myelination and synapses, things like that. If there is an underlying pathology, for example, a parenchymal disease like a meningoencephalopathy, some inflammation like HIE, then there would be asynchrony. If there is a structural malformation, for example, one side of the brain has got lissencephaly, so that persistent asynchrony in a particular part would draw the attention of the clinician towards that. So this is a synchronous record. In fact, it is more or less hypersynchronous. This waveforms are coming from both the sides together. Here, you can find out that they are occurring with a time gap. This is an asynchronous record. Voltage is important because voltage reflects as the amplitude. Range criteria is important when talking about voltage in neonates rather than strict cutoffs. However, if the voltage is more than or equal to 25 microvolts, whether the baby is sleeping or in REM, NREM or awake, then it is more or less normal. If it is less than 10 microvolts, it is abnormal. So this voltage criteria, in order to apply the voltage criteria, it need not be only a visual impression. For that, you have to play with the sensitivity that would be taught in the workshop, in the offline module. And then you have a scale in the EEG, the ruler, which is provided in the EEG screen itself. So with that, if you find that anything less than 25, you have to be careful. Electrocerebral inactivity is a term which is used in neonates as well as in children as well as in adults, which earlier used to be basically electrocerebral silence. It is a symbol. It is a marker of brain death. So, in case there is an absence of discernible cerebral activity more than or equal to 2 microvolts at recording sensitivity of 2 microvolts per millimeter, this is the standard definition, where you have a straight line sort of a image. This is a low voltage EEG. This is a scale which I was talking about. But there are some activities going on. It is not totally an electrocerebral silence. However, here, there is no activity at all. The background is like a straight line. And we have made the scale at 20 microvolts. However, there is no activity at all. This is ECI, electrocerebral inactivity. Then comes the term variability. So these terms which I am talking about, they are as per the ACNS guidelines, by which you have to score an EEG of a neonate by the headings, as per the headings which have been told. So then comes variability or lability. Variability refers to conspicuous, spontaneous EEG changes. So there are changes in EEG due to internal stimuli, like a baby who's sleeping has suddenly woken up or has started going from one stage of sleep to the other. So the domains which have to be looked are frequency, amplitude, and any change in the continuity. Before 25 weeks of gestation, nowadays we have got babies as young as 24, 23 weeks also surviving. So before 25, the variability is not marked. It gets well established by 30 to 31, and it is expected that the baby would react. There would be some variability. In the same lines, reactivity is a reaction, that is basically conspicuous, spontaneous, EEG responses to external stimuli, like any change in the state, any noise, any switching on of the light or photic. So there, the frequency, amplitude, continuity tends to change, and it appears at 30 to 32 weeks. A term which is commonly used in EEGs by maybe it is used quite often more than it is required to be used is dysmaturity. However, the textbook definition of dysmaturity is a disparity between the actual postmenstrual age and the EEG age. For example, if an EEG of a newborn is suggestive of an age of 30 weeks, but the baby is actually 34 weeks and the EEG has been read properly, then definitely it is a dysmature EEG. EEG is normal for a neonate who is at least 2 weeks younger. That refers to basically the cutoff which has been kept is 2 weeks. Suppose there is a gap of 1 week or 1.5 weeks, still it can pass on as normal. If dysmaturity persists in serial EEGs, it is a poor prognostic marker. And after these terms, we go to the difficult sounding name, grapho elements. So grapho elements are basically certain developmentally age appropriate background hallmarks in an EEG of a neonate. These markers are not present in the EEG of a child, of an adult, and these appear at a particular specific period of time, then they peak and they fade away, and they are generally symmetric. It is not possible, neither relevant to talk about all the grapho elements. However, we need to know them because they can confuse the EEG reader or the neurologist or the pediatrician. They may appear abnormal and may be reported as abnormal. This is as you can just focus on the laser pointer here on O1. These are waves which are of delta frequency, and on O2 also to some extent. So these are known as monorhythmic delta activities. They are commonly seen between 24 to 34 weeks, not seen beyond 35 weeks. They occur in bursts. Then comes a word delta brush. This you have been told about in children also. There are certain conditions where you see delta brush. However, in neonates, they are a normal grapho element, a normal developmental variant, which occurs between 24 to 36 weeks. They are also known as spindle delta bursts because here what happens, on top of a delta wave, which is occurring at a high amplitude, you have got superimposed waves which may be of beta frequency or alpha frequency. They, in the early neonatal age group till 32 weeks, occur only during active sleep, later as well as quiet sleep. However, later they occur only during active sleep, only during quiet sleep. Basically, here, this is taken from a standard textbook. This is a delta wave on top of which you can see these small, fine, spiky beta activity. They are the delta brushes which are happening. Anterior slow dysrhythmia is an anterior variant of developmental EEG manifestation, and this occurs in a theta frequency. So these words again, delta, theta, alpha, they may sound very scary initially, but once you start seeing the EEGs, they'll appear, they will come reflexively. So here anteriorly refers to the central. So C3, just focus on FP1, C3. These are of the theta range. Here in C4 also, wherever C is involved, CZ, C4, these are the anterior slow dysrhythmias. They again come in bursts. They are actually normal, but they may be reported as abnormal anterior epileptiform discharges. So after the grapho elements, the last part is the neonatal EEG transients. We have all heard about transients, the sharps, the spikes. However, most of the neonatal EEG transients are normal, and they can be either negative. The negative ones basically rise from the baseline upwards, and the positive ones go down. So these negative ones are generally physiological. Some of them may be abnormal. I'll show you how. Certain positive sharp wave transients and birds or brief intermittent rhythmic discharges or brief rhythmic discharges. So two snapshots of two EEGs have been shown here. Here, if you look at this wave, it looks as if there is a phase reversal. There is an epileptiform discharge here. However, it is just coming once in the entire report. The same thing on the lower snapshot is occurring again and again repetitively. This one is a normal one. This one is an abnormal one, likely abnormal one. It is occurring at the same place repetitively, and there is some amount of phase reversal here. So the moral of the story here is that while referring to epileptiform discharges or transients, though the electrographer, the EEG, the person who reports the EEG should be very, very confident that it is not abnormal, because if one unduly labels these as abnormal, then baby would unnaturally go on anti-epileptic drugs. The cutoff for spikes and sharps in neonatal is less than 100 milliseconds spikes, 100 to 200 sharps. With this cartoon, I would talk about the EEG maturation calendar. I would not venture to go into the development of sleep, development of vertex and things like that, because it would make the talk even more theoretical. So just focus on this. You see that every week, 2 weeks, the things are changing, and temporal theta bursts occur, they disappear, frontal sharp transients appear. So basically the moral of this cartoon is that the EEG in a neonate is very dynamic. as has been repeated already. And secondly, the background, reading the background is very important. Here, rather than focusing on the epileptiform discharges, I have been talking about the background and the grapho elements and things like that. However, when do we talk about a seizure? This is a snapshot of an electrographic seizure. Just focus on the tracings where the arrows have been pointed. There is some activity which is building up towards the left, and then it is evolving. They are becoming high amplitude, and it is initially probably starting at C3, this area, and then it is evolving all these areas. So this is an electrographic seizure which is persisting for 10 seconds or more. If there is a activity which is abnormal, which is changing in morphology, amplitude, frequency, and location, and lasting for 10 seconds or more, it is defined conventionally as an electrographic seizure. And these are the, so this is a chart which has been taken again from ILAE, where ultimately we have to focus on EEG. All the flowcharts, all the roads finally lead to an EEG. However, EEG is not sacrosanct for EEG is not foolproof, but clinical and EEG leads to a diagnosis of epileptiform discharges or an abnormal neonatal EEG. So with all that jargon, the steps in reading a neonatal EEG can be summarized by the following. First, you have to know the gestational age and conceptional age and the corrected age, sorry. You have to look at the background, whether it is normal, abnormal. Abnormal as far as the elements are there which should not be there, as the baby is beyond a particular age group and is dysmature or not. Any abnormalities, if there are abnormalities, then whether they are generalized or focal. Are there any seizures? And once you have seen that, does it fit into any particular neonatal epilepsy syndrome? That would only lead to the diagnosis. So with that, I would go to the next part of the talk, which is probably which would be more interesting, which is epileptic encephalopathies. So epileptic encephalopathies are defined as group of disorders where there is a deterioration of cognition and sensorial and or motor function due to this is a misprint due to seizure activity, and it is reflected by frequent seizures clinically as well as interictal epileptiform discharges. The beauty of epileptic encephalopathies is that it is highly age specific. We have different epileptic encephalopathies at different age groups. So due to the progressive maturation of the various areas of the brain, the EEG patterns as well as the clinical manifestations and the prognosis are different. In the neonatal age group, we have early epileptic encephalopathies. Then in infancy, we have West syndrome, and later we have LGS, Lennox-Gastaut syndrome. These are the these are the ones with the most bleakest prognosis, though there are many other epileptic encephalopathies which I'll cover. Investigation again depends on the clinical manifestation. A continuous EEG is desirable with more than 3 hours of monitoring along with video monitoring, but practically it may not be possible than at least a 40-minute record. And the EEG which has been told, an AEG as well as a long EEG record. It has been shown that the positive predictive value of AEG is around 78%, but it has limited accuracy and low sensitivity. So let us take certain case-based vignettes. We have the 5-month-old girl who had seizures from day 3 of life. And these seizures were of varied semiologies. This is a neonate. Just give me 1 second, please. So these, you can see these clonic movements which are occurring, the cycling sort of a movement. The eyes look up and to the left. Legs are also probably moving. And now this is actually, now you see the boy, the baby has gone into a tonic posturing. The head turns to one side and the video is short and the hands tighten up. The EEG is not of this baby, but we have taken a representative EEG, which was a similar EEG. It was a classical burst suppression pattern. After detailed workup, the baby turned out to be that of an Otara syndrome with some structural abnormality in the brain. I'll talk about that. But before that, let's see another video. This is a video of a baby who so here, if you see sort of jitteriness, but it's actually not jitteriness. There are small brief myoclonic activity involving the limbs, lower limbs, upper limbs, with no stereotype, with no regular fashion. In fact, it is more like a myoclonus. So initially, this baby had given us a lot of problems. We had thought of hypocalcemia, hypoglycemia, we had thought of jitteriness, but finally it turned out to be a early myoclonic epilepsy. This is again a rare epileptic encephalopathy which manifests in the first few days of life. The baby has predominantly myoclonus, lot of myoclonic activity, and later can have tonic seizures also. Etiology is metabolic in this case. For example, non-ketotic hyperglycinemia. And EEG is again a burst suppression pattern, which becomes even more prominent when the baby is in deep sleep. So these two terms, the early infantile epileptic encephalopathy, the Otara, which was the earlier video, and the early myoclonic epilepsy, ACARD, they vary in type of the seizures, the tonic seizures in the previous and the massive myoclonus. The Otahara is secondarily due to a structural brain malformation, and EME is due to metabolic disorders. EEG is the same in both. However, I would like to caution the junior physicians here, pediatricians here, that you should be careful. This don't go about labeling as EME in any myoclonus you see. This is benign sleep myoclonus. When the baby was woken up, it's a normal baby. When the baby was waken up, the baby became absolutely normal. So it is very common that these babies may be put on anti-epileptic drugs, and many a time EEGs are done, which are reported as abnormal due to the grapho elements. There is another rare epileptic encephalopathy of neonatal and early infantile age group is malignant migrating partial seizures or Coppola syndrome. The range of onset age is huge from 1st to 10th month. Seizures are focal motor, and they can be basically, they change their sides from left to right. All four limbs are involved, and they are associated with developmental delay and regression. The earlier two ones, both your EME and Otahara, may be fatal. Coppolas generally survive with a bad cognitive outcome. It happens due to a genetic etiology. This is a picture of a 6-month-old boy who had seizures from 3.5 months. You see the epileptiform discharges, which unfortunately this is too small to be read here probably. So they are varying, and here is an ictal event which is occurring. Let's take another case, a 9-month-old baby who is developmentally delayed, and the answer is out. The baby has flexor spasms. The baby has sudden jerky movements of the upper limbs and lower limbs. They occur in clusters, and these clusters are exacerbated when the child gets up from sleep or the child is going to sleep. So we are talking about West syndrome, and as all know, it is a triad basically spasms, developmental delay, and hips arrhythmia characterized patient as having West syndrome. The etiologies are varied. So here we are interested on EEG only. Hips arrhythmia is the hallmark signature EEG of West syndrome. It is a very hips refers to high altitude, high volume, high amplitude. So it is high voltage, more than 200 microvolts, slow waves on a very chaotic random background, which is highly asynchronous. And there are a lot of spikes, sharps, there can be bispikes, polyspikes, maybe occipital dominant, that is amplitudes may be more on the occipit, or it may be varying. And there is an electro-decremental response. After a spasm, there is a sudden attenuation in the amplitude of the EEG. I'll show you. This is taken from a textbook. These are the high amplitude waves which are getting a cutoff. As if you can look at the cursor, there's a cutoff here because the amplitude is too big. It is so, and if it is decreased, the sensitivity is decreased, then you see that there are high amplitude spikes, sharps, spikes. Somewhere you can see bispikes also, and it is a chaotic background. There are no sleep markers. And after a spasm, there is sudden attenuation, which is the electrodecremental pattern. So this is a baby. And this is her EEG, where you see the background is chaotic. There is no synchronicity. And these high amplitude areas are having spikes, bispikes, polyspikes. And there is some attenuation in between. There is some beta activity here. Here it is appearing like bursts coming again and again. The EEG goes on like this. This is hips arrhythmia. On the other hand, modified hips arrhythmia is something which we frequently see. This I'm just sensitizing. I won't be going into details. There can be certain conditions like increased interhemispheric synchronization or burst suppression or consistent voltage asymmetry, which also qualify as hips arrhythmia, but as modified hips arrhythmia. This is a modified hips arrhythmia of a burst attenuation pattern. Whereas this is an asymmetric record. If you see, sorry, the left and the right, the abnormalities are appearing from the odd numbered ones. That is, they are appearing from the left. Now we go to another epileptic encephalopathy. So here I am walking away from neonatal age group, but then
Dr. Goswami, please wind up. We have only 15 minutes left. No?
Okay. So you see the baby is having drop attacks. She also has a lot of other seizures on multiple anti-epileptics, developmentally delayed. Case of Lennox-Gastaut syndrome. Tonic seizures are the hallmark, though there can be other seizures also. The EEG has got two characteristics: slow spike wave pattern and a paroxysmal fast activity. These are the slow spike wave, less than 3 Hertz, generally frontocentrally involved, and these are the paroxysmal fast activities occurring at beta frequency. This is a focal PFA. The left side is paired, and this is a generalized PFA. This is an EEG from a patient treated in our center. These are the PFAs, and these are the slow spike wave activities, Lennox-Gastaut syndrome. A child with Dravet syndrome who has initial febrile followed by afebrile seizures, and later the EEG worsens, has generalized spike waves and polyspike discharges. And this is a characteristic EEG of a Dravet syndrome. On the other hand, a similar disease, multiple polymorphic seizures, myoclonic jerks with no marked cognitive regression, is Doucet syndrome, which is pronounced as DOSA, myoclonic aesthetic epilepsy. And in myoclonic aesthetic epilepsy, the EEG background is normal. You have 2 to 3 Hertz generalized spike wave discharges. A child who has got absent-mindedness and poor interaction, no overt seizures. EEG awake state more or less normal. When he sleeps, the EEG becomes ruthlessly abnormal with lot of generalized spike wave discharges. When the sensitivity is changed, it appears like that. You have got spikes and waves, frontally dominant. And it is basically a case of CSWS, ESCS, electrical status epilepticus in slow wave sleep. And a similar entity, Landau-Kleffner syndrome, which has anterior abnormalities along with language regression, is LKS. So the carry home messages which I would like to give after this heavy presentation is to give an overview of neonatal EEG, talk about the importance of certain why to get a neonatal EEG, the salient peculiarities and the maturational patterns and the terminologies, and the steps in reading a neonatal EEG, where we focus on the background and a bird's eye view of few common epileptic encephalopathies. With this, I finish.
Thank you.
Thank you, sir.
Thank you, Dr. Goswami. And literally, it's very difficult to speak anything after your presentation because you are so elaborate and it's so detailed as well as so interesting. We could have one more day for more interactions. Now I feel, Dr. Praveen, that we are still lagging behind. We can discuss many of the things. Initially, what persons usually used to say that for EEG, why so much time? It is hardly 2 or 3 hours job for all basic training and workshop. I told, okay, let us go ahead. And now, as the time is, I think it's 4:50 already. We have 10 to 15 minutes time. I would like to just give a very brief idea about something which is very important. Actually, what you discussed today was advanced course, and this is very basic. जो यूजुअली पीडियाट्रिशियंस को, जनरल पीडियाट्रिशियंस को जिस चीज से मतलब है, हम लोग अब आने वाले जितना भी समय बचा है उस चीज के ऊपर एक बार पूरी तरह से फिर से रिकैपिचुलेट करते हैं और उनको कुछ और टेक होम मैसेज देते हैं. सो स्टार्टिंग माय प्रेजेंटेशन विद दिस सिंपल थिंग्स. सो what is जो हम लोग का फर्स्ट लेक्चर था, that was indications of EEG in childhood epilepsy. If you keep in mind these 6 things only, then you can do better use of EEG. Like it supports diagnosis of epilepsy when clinical history is suggested. It helps in identifying seizure type and epilepsy syndrome. Many a times सीजर आया, हमने अटेंडेंट्स ने जो एक्सप्लेन किया, हमने एक डायग्नोसिस लिखी सीजर और उसको सीटी, ईजी, एमआरआई वगैरह सब करा करके ब्रॉड लेवल हम लोगों ने अगर फोकल और जनरलाइज ही एस्टेब्लिश कर लिया, वी आर क्वाइट हैप्पी विद दैट. But more and more seizure you are going to watch and different EEG patterns, and if you recognize the epilepsy syndrome, then you are better placed for explaining the prognosis as well as a better rational treatment. And not only rational treatment, but when to refer, to whom to refer. So it's all about practice and practice. Then prognosis and deciding duration of treatment. Then pre-surgical evaluation of intractable epilepsy and diagnosing paroxysmal non-epileptic events, pseudo-seizures, parasomnias, and diagnosing non-convulsive status epilepticus, especially in case of ICU setting. And remember that EEG should not be used for excluding epilepsy in case of paroxysmal events, because when you get EEG once or twice or thrice does not means if it is normal, then this does not exclude epilepsy, because epilepsy is purely a paroxysmal event. और हमें ये कोशिश करनी है कि एपिलेप्सी में हम किस तरह से बेहतर ईल्ड ले पाएं EEG का, तो वो हमारे लिए ज्यादा फायदेमंद है बजाय इसके कि नॉर्मल आया, चलो कुछ नहीं, इसमें आगे काम बढ़ाते हैं, या दूसरी बार ईजी करा लिया, दो बार तो नॉर्मल हो गया, अब क्या करना है. सो वी हैव टू कीप इन माइंड. Or syncope, migraine, breath holding spell, simple febrile seizure. Of course, complex febrile seizure, there is some role, but for simple febrile seizure, it is a clinical diagnosis. And brief acute symptomatic seizures like risk of false positive results, you have to keep in mind. So this is, and this is another take home message is appropriately ordered. कब करना है, कैसे करना है. तो यूजुअली जब भी लास्ट सीजर है, उसके 3 to 4 डेज इंटरवल के बीच में, ये बिल्कुल ये मेरे ये दिस इज दोनों को दोनों कॉन्ट्राडिक्टरी बातें हैं. फर्स्ट थिंग ये कहते हैं कि एक बार सीजर हुआ तो उसके बाद पोस्ट इक्टल स्लोइंग हो गई, तो वो 3-4 दिन तक रहती है. ये प्रिफरेबली हम लोगों को 3-4 दिन बाद कराना चाहिए, एंड 4 वीक्स के पहले, 4 वीक्स के पहले, 4 डेज के बाद, ये टाइम होना चाहिए. मैक्सिमम 4 वीक्स, minimum 4 days. But some studies have shown that higher yield with EEG if performed within 24 hours of seizure event, 15 to 35% can be picked up. So there is doubt between different neurology groups. So now about time. Standard routine is 30 minutes EEG in wakefulness with fatigue stimulation and hyperventilation, जो कि we can do in older children and adolescents. And EEG after sleep deprivation improves detection of abnormalities, we already know. So first, this is different. One take home message is, first, unprovoked afebrile seizure, the best investigation is EEG, because it helps in syndrome identification and prediction of recurrence. And the risk of recurrence is increased by interictal spike discharge, especially focal spikes. So first, unprovoked afebrile seizure, you should go always with for an EEG done. And then these are the limitations of EEG. We know that poor इसमें हम लोग वही पिक कर सकते हैं जो थोड़ा सुपरफिशियल है, जो थोड़ा कॉर्टिकल है. इसका इटियोलॉजी नहीं पता कर सकते. इट हैज रिलेटिवली लो सेंसिटिविटी. इसको करीब 500 टाइम्स और 1000 टाइम्स इसके उसके जब ऑगमेंट करते हैं तब जाकर उसकी ट्रेसिंग आती है. एंड दीज आर सब्जेक्ट टू बोथ फिजिकल एंड इलेक्ट्रिकल आर्टिफैक्ट्स and influenced by a state of alertness, hypoglycemia, drugs. Small lesion, deep lesion may not produce any EEG abnormality, and limited time sampling for routine EEG restricts its predictive value. कि 40 मिनट में, आधा घंटे में अगर कुछ हुआ तो हुआ, नहीं तो अगर वो टाइम इंटरवल के बाद कुछ हो रहा है तो वो हमारे लिए किसी इस्तेमाल का नहीं है. So an EEG is a sampling of brain activity occurring at the time of recording. Seizures are paroxysmal in nature, so it has limited use. So finally, remember, an abnormal EEG does not necessarily mean epilepsy. 10% of people without seizures can have non-specific EEG abnormality. Decision to start AED is based on recurrence risk of seizure and not only abnormal EEG. That someone has asked question, so answer is this. If it जैसे अगर it development, there may be difference of opinion, okay, so I don't care, you have to take your own call. But suppose that there was one case that was written in chat box or somewhere, if a child is developmentally retarded and there is history of you say birth asphyxia or so, EEG is abnormal but no clinical seizure is there. So whether you will start AED or not. So my point is, AED is based on recurrence. In this case, when EEG is abnormal and when development is retarded and there is history of HI, there is fair chance of seizure recurrence. So we can think of starting AED. Let us discuss further. So always try to obtain sleep record. Some abnormalities occur only in sleep. Some from transition from sleep to awake state, and some abnormalities are specific for awake state. So it is always better if it can be done that we obtain 20-25 minutes of sleep record, then transition 5 to 6 minutes of transition, then awake state record. That will give best result. That is ideal. And of course, video EEG is definitely better to correlate findings. So now, some action. What are we going to do? एक ये आपके सामने EEG बहुत क्लियर नहीं है, चलिए सेकंड देखते हैं. ये एक EEG जो आ रही है, तो अब हम लोग बिल्कुल लास्ट मोमेंट्स पे हैं. तो अगर किसी भी EEG को एक बिगिनर जैसे यूजी स्टूडेंट को ECG पढ़ना सिखाते हैं कि सबसे पहले रेट देखो, रिदम देखो, RR इंटरवल देखो, ये देखो, वो देखो, तो बड़े बड़े सिंड्रोम तो बाद में पहचानना है. एक्चुअली EEG और ECG की लैंग्वेज में एक बेसिक अंतर है. इसमें जो सबसे नीचे वाली लाइन आप देख रहे हैं, ये लाइन, ये आपकी ECG की लाइन है, ठीक है. तो इसमें आप देखो ECG में एक ही पैटर्न बार बार होता है. EEG में इट्स ऑलवेज चेंजिंग पैटर्न. ओके, नंबर 1. तो EEG को पढ़ने में बेसिकली जो हम लोगों को किन पॉइंट्स का ध्यान देना है, इट इज एन स्क्रिप्ट जो कि लिखा हुआ है. इस स्क्रिप्ट को हमें पहले डिकोड करना है. डिकोड करने में शुरू से ये बातें हो रही हैं कि हमें बेसिकली पहले पहचानना है कि जैसे ये मानकर चलिए आप कि यहाँ एक पॉइंट से लेकर के ये इस पॉइंट से इस पॉइंट तक एक सेकेंड का है. तो इसमें कितना वो वेव्स कितनी आ रही है, ठीक है. उसके हिसाब से फिर हम लोग प्लान करते हैं कि इफ कौन सी वेव है, अल्फा है, बीटा है, थीटा है या बीटा है. तो वी काउंट, पहले तो ये पहचानना. बेसिक डिकोडिंग इज कि टेक एनी पैटर्न से यू सी, इसको हम डॉक्टर प्रवीण ने बताया बेटा, से दिस पैटर्न यू स्टार्ट काउंटिंग, इट्स 1 2 3, कहीं पर भी काउंट करो आप, तो वो एक पैटर्न अपना एक बन करके आएगा कि ये जो है 1 सेकेंड में 4 सेकेंड ये, 5 सेकेंड ये, इन दोनों के बीच में कितना ये हो रहा है, ये कितना आ रहा है, 1 2, थोड़ा सा ये आइसो इलेक्ट्रिक साइड में है, और ये सर. सो सबसे किस तरह से हमें बढ़ना है ये बताएंगे. तो डॉक्टर प्रवीण आप बताइए कि इसको इस EEG को रिपोर्ट कैसे करेंगे, क्या रिपोर्ट करेंगे इस EEG को आप?
अच्छा बॉस, आई कांट सी द EEGs बिकॉज़ शेयरिंग करनी मुझे लगता है क्या? हाँ,
दिख नहीं रहा है आपको?
नहीं, आई कैन जस्ट सी यू करके, मैं आपको सिर्फ देख पा रहा हूँ.
एक मिनट, अभी मैं दिखा रहा हूं. अभी आ रहा है?
हाँ, सो हम लोग उसको ये भी कर सकते हैं क्या?
हाँ करते हैं,
लार्ज कर लेते हैं क्या?
अभी करते हैं. ये ठीक है. अब आप इसको बिल्कुल बेसिक्स के तौर पे पढ़ा जाए. सबसे पहले हम लोग जो पढ़ते हैं वहां से स्टार्ट करते हैं. दैट इज पोजीशन 10 to 20 सिस्टम. सारे ऑडियंस, दिस इज स्पेशली फॉर ऑल डेलीगेट्स. आज मेरे पास जो फीडबैक आए थे उसकी वजह से हमने आखिरी 5 मिनट इस चीज के लिए अलग किया है, और इसी चीज को हम लोग बार बार प्रैक्टिस करेंगे संडे के दिन. तो इसको बहुत बेसिक में चलते हैं. तो ये 10-20 सिस्टम ऑफ इलेक्ट्रोड प्लेसमेंट है, यू कैन सी. अब इसमें बाइपोलर है. देन अदर थिंग, फर्स्ट थिंग दैट इज बैकग्राउंड. बैकग्राउंड के बारे में कमेंट करेंगे. तो बैकग्राउंड में आप देख रहे हो एक मोस्टली ऑर्गेनाइज्ड बैकग्राउंड है. बैकग्राउंड इज ऑर्गेनाइज्ड. देयर इज सिमेट्री बिटवीन, यू कैन सी एक सिमेट्री बना हुआ है. जो नीचे जा रहा है तो सारे वेव्स नीचे ही हैं ऑलमोस्ट, ठीक है. तो सिमेट्री इज मेंटेन्ड. ये सिमेट्री तब होती है जब राइट अलग जा रहा है, लेफ्ट अलग जा रहा है, या कहीं पे किसी तरह की सिमेट्री. तो ऑर्गेनाइज्ड देयर, ठीक है. नाउ हाउ टू से इट इज एंटीरियर डोमिनेंट और पोस्टीरियर डोमिनेंट. तो पोस्टीरियर, डॉक्टर प्रवीण इसको, आप यहाँ पे हो डॉक्टर प्रवीण, हाउ कैन यू से इट इज पोस्टीरियर डोमिनेंट?
सो दो चीजें हैं. जब कभी मैं थोड़ा सा उसमें और ऐड कर देता हूँ सर वहां से, प्लीज द पार्ट है कि जब कभी हम लोग EEG पढ़ते हैं या उसके बाद उसकी रिपोर्टिंग की बात करते हैं तो कुछ पॉइंट्स हम लेके चलते हैं. एक तो टेक्निक, कौन सी टेक्निक हो रही है. जैसे आपने कहा कि हमने 10-20 सिस्टम अलाउ किया हुआ है और उसमें हमने लिखा हुआ है कि ये स्लीप में है कि वेकफुलनेस में है, क्योंकि वो हमें पढ़ने के समय रिक्वायरमेंट होगी। और स्लीप में है तो वो सिडेशन के साथ का स्लीप है या नॉर्मल स्लीप का पार्ट है, क्योंकि अगर पूरी स्लीप नहीं है तो हम लोग वेकफुलनेस का रिकॉर्ड को नहीं देख पाएंगे फिर वो, ठीक है। और कितना एज है पेशेंट का, जैसे लास्ट हम लोगों ने बात करी थी कि जो पोस्टीरियर डोमिनेंट रिदम होता है वो एज डिपेंडेंट होता है उसके साथ में। तो कम से कम हमारा स्लीप अवेक का पार्ट और दूसरा की एज का पार्ट हमारे टेक्नीशियंस के साथ में मेंशन होना चाहिए, पहली चीज है। और सेकेंड पार्ट फिर वो उसको देखते हैं कि उसका फाइंडिंग्स क्या है, फाइंडिंग्स उसकी वेकफुलनेस में क्या है, फाइंडिंग्स उसकी स्लीप में क्या है, और इसके बीच में फाइंडिंग्स की 40 के स्टिमुलेशन में या फिर उसके हाइपरवेंटिलेशन में क्या है, और फिर उसके बाद कोई आर्टिफैक्ट्स तो नहीं है, और उसके बाद कोई एबनॉर्मल फाइंडिंग्स का पार्ट तो नहीं आता है फिर वो। तो अगर हम इसके बारे में बात करें तो और तो हमें ये पता नहीं है कि ये स्लीप का पार्ट है या अवेक का पार्ट, लेकिन हम देख पाते हैं कि जो इसमें कुछ आई मूवमेंट के आर्टिफैक्ट्स हैं, जो ये पार्ट दिख रहा है, तो कहीं ना कहीं जो पेशेंट है हो सकता है कि वो अवेक के फेज में हो, पहली चीज है। सेकेंड चीज क्या है कि जब हम लोग बात करते हैं, सर ने भी बोला कि वेकफुलनेस में हम बात करते हैं कि व्हाट इज द बैकग्राउंड रिदम। बैकग्राउंड रिदम पे हम लोग उसको पोस्टेरियरली देखते हैं, पोस्टेरियर मतलब कि हम उसको ऑक्सीपिटल लोब में देखते हैं कि यहाँ पे कितना रिदम आ रहा है। तो ये चीजें यहाँ पे इतनी क्लियर नहीं है, लेकिन यहाँ पे हो सकता है कि दिख जाए करके फिर वो डेफिनेटली इज मोर देन अराउंड 10 प्लस ही हर्ट्ज के आसपास में होगी इसकी फिर वो रिदम। तो अगर आप काउंट करेंगे तो इट विल मोर देन 10 हर्ट्ज, ऑलमोस्ट अराउंड 10 to 11 हर्ट्ज के आसपास है इस पार्ट में। थर्ड ये होता है कि एंटेरो पोस्टीरियर ग्रेडियंट है कि नहीं है, जो हम बात कर रहे थे। तो उसका मतलब है कि एंटेरो पोस्टीरियर ग्रेडियंट का मतलब होता है कि हम जब एंटेरियरली जो वेव्स होते हैं उनकी फ्रीक्वेंसी ऑन द हायर साइड पे होती है, और पोस्टीरियरली जो हमारी वेव्स होती है उनकी फ्रीक्वेंसी ऑन द लोअर साइड पे होती है। मतलब एंटेरियरली आपको कॉमनली बीटा वेव्स का पार्ट मिलेगा और पोस्टीरियरली आपको अल्फा का पार्ट मिलेगा फिर वो, अगर हम वेवफुलनेस की बात करें। और एंटेरियरली एम्पलीट्यूड ऑन द लोअर साइड पे होगा और पोस्टीरियरली एम्पलीट्यूड स्लाइटली ऑन द हायर साइड पे होगा। तो अगर हमें इस तरह की चीजें मिलती हैं तो उसको हम लोग कहते हैं कि एंटेरो पोस्टीरियर ग्रेडियंट का पार्ट है। तो अगर मुझे ये इस ईईजी के बारे में बोलना हुआ कि ये ईईजी का पार्ट है, तब आई विल से कि ये दिस इज एंड EEG recorded in the 10-20 system in the wakefulness state. The EEG has a normal background rhythm consisting of almost around 10 to 12 hertz posterior dominant rhythm, which is reactive to eye opening. जब आप eye open करेंगे तो चीजें खत्म हो जाती हैं या नहीं ओपन रहती हैं फिर वो।
मुझे ये लगता है कि ये जो है दिस इज मोस्टली एटेन्युएटेड पार्ट, मोस्ट लाइकली आई ओपन में है, यहाँ पे आई क्लोज किया है क्या?
हाँ तभी आपका पोस्टीरियर डोमिनेंट बाद शुरू हो गया मिलने का
पर इसमें हाँ इसके बाद पोस्टीरियर डोमिनेंट शुरू हो गया है। तो दिस इज पार्ट ऑफ एटेन्युएशन। एटेन्युएशन मतलब जब आप आईज खोलते हैं तो वो ये जो पार्ट है वो पूरा, दिस इज अवेक बट आई क्लोज्ड, ओके, एंड दिस इज अवेक एंड आई ओपन। तो वो आपको उस पे ध्यान देना होता है, ओके। तो ये इसको एक तरह से कहा जाए तो दिस इज नॉर्मल ईजी, ओके ओके। सो इसके ऊपर बताइए ये इसमें क्या कहना चाहिए?
हाँ ये अच्छी ईजी, अगर हम इसको देखें दूसरा पार्ट है कि ये
स्टार्ट से ही बताएंगे हम लोग, सीधे पॉजिटिव फाइंडिंग बाद में, पहले रीड करना है इसको।
तो जैसे अगर आप इसको देखें तो ये अगर हम इसको देखें तो सिमिलरली हम देखते हैं कि एक तो ये एवरेज मोन्टाज की ईईजी है, मतलब कि हमारे पास में सारे जो ये सीजेड के साथ में कनेक्टेड ईईजी, जो हम बात कर रहे थे मोन्टाज के बारे में, तो ये एवरेज मोन्टाज की ईईजी है। हमारे इलेक्ट्रोड जो है वो एवरेज मोन्टाज के साथ में कनेक्टेड है। और जब हम एवरेज मोन्टाज की बात करते हैं तो इसमें जो हमारा पहले से ही कॉन्सेप्ट बन जाता है कि जहां पे वोल्टेज ज्यादा दिखेगा वहां पे एबनॉर्मलिटीज का पार्ट होगा, ठीक है, पहली चीज है। सेकेंड चीज अगर हम इसमें देखें तो ये हमारा 1 2 7 8 जो इवन नंबर्स वाले होंगे वो राइट साइड के होंगे, जो ऑड नंबर्स वाले होंगे वो लेफ्ट पार्ट ऑफ द ब्रेन के होंगे फिर वो। तो अगर हम इसमें अगर बैकग्राउंड की बात करें तो बैकग्राउंड के लिए अगर हम फिर से जाना पड़ेगा तो हमें उसको देखना पड़ेगा कि O1 O2 का बैकग्राउंड कैसा है, O1 में कैसा है, कितने वेव्स दिख रहे हैं आपको एक सेकेंड के अंदर में, O2 है कहाँ पे, O2 को नीचे ढूंढना पड़ेगा, O2 कहाँ पे है, O2 में कितने वेव्स हमें दिख रहे हैं इस 1 सेकेंड के अंदर में, तो वो हमें एक बैकग्राउंड के बारे में बताएगा। एक कॉन्टिन्यूअस बैकग्राउंड का पार्ट तो उसके साथ में नहीं है, कोई हमारे पास में आई ओपनिंग आई क्लोजर का पार्ट नहीं है। तीसरा में और क्या देख रहे हैं कि कोई एंटेरो पोस्टीरियर डोमिनेंस हम नॉर्मली बाइपोलर मोन्टाज में देखते हैं, एवरेज मोन्टाज में वो चीजें नहीं दिखेंगी हमारे पास में। रिएक्टिव टू आई ओपनिंग का पार्ट इसमें नहीं दिखेगा हमारे साथ में फिर वो, ठीक है। तो बैकग्राउंड इसकी कॉन्टिन्यूअस है, मे बी एट प्रेजेंट आई मीन हमें ये देखना पड़ेगा कि ये डिस्चार्जेस हैं, उसके बाद में थोड़ा सा अटेन्यूएशन ऑफ बैकग्राउंड का एक्टिविटी का पार्ट है, डिस्चार्जेस के पास में एटेन्यूएशन ऑफ बैकग्राउंड एक्टिविटी का पार्ट है, ठीक है। इसके साथ में तो अगर हम इस बैकग्राउंड की बात करें तो उसको हम लोग एक कॉन्टिन्यूअस बैकग्राउंड की तरह लेकर नहीं चल पाएंगे, ये बैकग्राउंड डिस्चार्ज के बाद में थोड़ा सा अटेन्यूएशन ऑफ बैकग्राउंड एक्टिविटी का पार्ट है। एवरेज मोन्टाज में है what we can say that this has got diffuse sharp wave activity, possibly spike wave activity, diffuse discharges followed by attenuation of background activity। लेकिन हमेशा बेहतर होगा हम लोग इसको एक एंटेरो पोस्टीरियर मोन्टाज में भी देखें, जिससे कि हमें वो चीजें और बेहतर दिखे। and at the most what we can see that the maximum voltage is around the T2 area, so T2 area and at the temporal location on the part।
Great। so इसमें हम लोगों ने देखा दिस इज फाइनल रिपोर्टिंग में आएगा, दिस इज राइट टेम्पोरल शार्प वेव्स विच आर मैक्सिमल एट T2। so ये इसमें एक पॉइंट बन सकता है। देन कमिंग टू नेक्स्ट, इसमें बताएं।
हाँ, तो जैसे कि हम लोग इस EEG को
एक मिनट पहले कोई ट्राई करना चाहेगा, हमारा कोई डेलीगेट ट्राई करना चाहेगा?
हाँ, दैट विल बी गुड।
कुछ बोले, गलत बोलने से कोई यहाँ बेइज्जती नहीं होने जा रही है। एनीवन कैन आंसर? ट्राई करो। अभिषेक करोगे क्या? नो वन इज इंटरेस्टेड। ओके, यू प्लीज कैरी ऑन।
हाँ, तो अगर हम इस EEG को देखें तो हमें पहले पता है कि ये EEG जो हमारी है वो बाइपोलर मोन्टाज में है, F2, F8, T4, T6 इसके साथ में है। ये हमारा राइट पार्ट ऑफ द ब्रेन हो गया और ये हमारा लेफ्ट पार्ट ऑफ द ब्रेन हो गया, ठीक है। जैसे हम लोग बात कर रहे थे कि हम देखते हैं पहले कि उसका कि वे वेकफुलनेस में है तो हमारी रिदम कैसी है, हाउ इज द बैकग्राउंड रिदम। बैकग्राउंड रिदम हम पोस्टेरियरली देखते हैं, T6 O2 में कैसा है, तो ऑलमोस्ट हम देखेंगे तो स्लाइटली ऑन द स्लोअर साइड पे होगा। फिर वो अगर हम वेव्स देखेंगे, ये 1 सेकेंड है, इसके बीच में कितने वेव्स बन रहे हैं, 1 2 3 4, 1 2 4, ऑलमोस्ट 4 वेव्स बन रहे हैं राइट साइड में। और हम लेफ्ट में देखें तो इसके वेव्स हमें क्लियरली दिख नहीं रहे हैं लेफ्ट साइड में, ठीक है, इस पार्ट के साथ में। तो अगर हम बैकग्राउंड की बात करें तो बैकग्राउंड एक्टिविटी जो है इसकी ऑन द थीटा रेंज पे है, सॉरी हाँ डेल्टा रेंज पे है, और लेफ्ट पार्ट ऑफ द एक्टिविटी, लेफ्ट पार्ट ऑफ द हेमिस्फीयर में अच्छी बैकग्राउंड एक्टिविटी नहीं दिख रही है, पहली चीज है। सेकेंड चीज क्या है, उसके साथ में बैकग्राउंड कैसा है, कॉन्टिन्यूअस है, कॉन्टिन्यूअस बैकग्राउंड है, ऐसा कोई वहां पे कोई अटेन्यूएशन बैकग्राउंड एक्टिविटीज की नहीं है। कोई एसिमेट्री है, डेफिनेटली है। राइट पार्ट ऑफ द ब्रेन में हमें देखते हैं कि हमें वेव्स क्लियरली दिख रहे हैं, और जो हमारा लेफ्ट पार्ट ऑफ द ब्रेन है उसमें वेव्स उतने क्लियरली नहीं है, एसिमेट्रिकली हो सकता है कि ऑन द स्मॉलर साइड पे हो। नॉर्मली हमारा लेफ्ट पार्ट ऑफ द ब्रेन में जो वैसे भी वेव्स होते हैं उनकी एम्पलीट्यूड थोड़ा सा कमी होती है एज कंपेयर टू द राइट पार्ट ऑफ द ब्रेन के साथ में। और हमें क्या दिख रहा है इसमें, हमें कुछ यहाँ बहुत ही शार्पिश एक्टिविटी दिख रही है, दे आर लाइक थॉर्न, एकदम थॉर्न की तरह से हैं, so they do not appear to be true spikes, they appear like they could be kind of like artifacts। इसके साथ में उस पार्ट के साथ में है हमें, और इसके साथ में वेव्स दिख रहे हैं कि फ्रंटली हमें फास्टर एक्टिविटीज दिख रही हैं जो कि ऑन टॉप ऑफ द स्लोअर एक्टिविटीज होंगी,
ठीक
इस
है,
पार्ट में। तो अगर हमें देखना हुआ तो इसमें व्हाट वी आर फाइंडिंग ग्लेरिंग इज दिस कि इट हैज गॉट सम राइट पोस्टेरियर स्लो वेव्स। अगर हम इसको समझने की कोशिश करें इसके साथ में तो फिर
ठीक, परफेक्ट। इसमें
हाँ देखिए, ये दिस इज आल्सो एंटेरियर पोस्टेरियर मोन्टाज। अगर हम देखें तो लेफ्ट पार्ट ऑफ द ब्रेन है, ये राइट है, फिर ये लेफ्ट है, फिर राइट है, और हमें क्या दिख रहा है कि बैकग्राउंड ठीक है, ऑलमोस्ट कॉन्टिन्यूअस बैकग्राउंड है, दोनों तरफ में कॉन्टिन्यूअस बैकग्राउंड है, और हमें दिख रहा है कि जो राइट और लेफ्ट पार्ट के पोस्टेरियरली में स्पेशली व्हाट वी आर गेटिंग इज बेसिकली द स्पाइक वेव डिस्चार्जेस। So these are the spike waves.
spike wave reason that is there, occipital posterior spikes.
तो posteriorly spike wave discharge हमें दिख रहे हैं clearly. Good. ये वेव भी हमारा अगर हम देखें तो ये बाइपोलर मोन्टाज में है, और ये हमारा लेफ्ट पार्ट ऑफ द ब्रेन हो गया, ये भी लेफ्ट है, फिर ये राइट है, फिर राइट है। अगर हम देखें बैकग्राउंड एक्टिविटीज तो ठीक है, O1 में ऑलमोस्ट कॉन्टिन्यूअस है, O2 में ऑलमोस्ट कॉन्टिन्यूअस है इसके साथ में। और हम देखते हैं जैसे अभी पहले वाले में हम लोग बात कर रहे थे कि हमारी ये आई ओपनिंग आई क्लोजर वाले आर्टिफैक्ट्स हैं कि हम आई ओपनिंग और आई क्लोजर के साथ में हम अपने बैकग्राउंड एक्टिविटी में कोई सिग्निफिकेंट चेंज देखते हैं या नहीं देखते हैं। बहुत सिग्निफिकेंट चेंजेस तो यहाँ पे
नहीं, ये आई बेसिकली आई ओपनिंग आर्टिफैक्ट्स।
हाँ, इसके साथ
ये सारे पोस्टीरियर डोमिनेंट रिदम उसी चीज का एक्सप्लेनेशन है। सो थैंक यू वेरी मच। और
डिस्कस करेंगे संडे को।
हाँ,
और वो
हाँ,
1-to-1 डिस्कस करेंगे जो हम लोग का प्लान था। इट विल बी रियली रियली यूजफुल फॉर ऑल ऑफ अस इन द पार्ट। हम लोग एक ईजी को लेकर डिस्कस करेंगे।
बिल्कुल वैसे ही करेंगे। और ये किसी और कोई और सवाल किसी का बच गया हो? आई थिंक all questions in chat box has been addressed, no?
बस एक मेरा सजेशन है कि इस अभी तो हमारा ऑलरेडी ओपन है, तो कुछ हमारे जो सजेशंस होंगे, बिकॉज वी आर मीटिंग ऑन संडे, कुछ और भी हमारे डेलीगेट्स के सजेशन होंगे या क्वेश्चंस होंगे, तो वो पहले से अगर भेज देंगे तो विल ट्राई कि हम लोग उस चीज को वहां भी इंक्लूड कर सकें।
अभिषेक बंसल, आपका क्या है इनपुट दे दीजिए जल्दी से तैयारी के लिए।
हम लोग उसको भी इंक्लूड कर लेंगे वहां पे।
चलिए ठीक है। मैं आपको बताता हूँ प्राइमरीली यही है कि पीपल वांट मोर एंड मोर हैंड्स ऑन rather than on theory।
हाँ, नहीं हम लोग बात भी कर लेंगे सर।
हाँ, तो आप जो है ना कुछ प्रिंट आउट्स अपना जितना ज्यादा हो सके वो लेते आएंगे, ठीक है? तो जो लोग हमारे साथ ऑफलाइन नहीं आ रहे हैं उनके साथ अभी का ये समय खत्म होता है। मुझे लगता है कि जितने लोग हैं उसमें शायद सभी को आना चाहिए। फिर भी if there is the WhatsApp group will remain there. If you want to raise any query or do any comment, you are welcome there. And so thank you all, thank you organizers, and a special thank you Dr. Goswami. We are going to miss you. Better luck next time. फिर कभी हम लोग मिलते हैं, ठीक है? So
I will also miss sir. Thank you so much sir. And thank you Dr.
आप
Praveen.
अपना आज वाला भी दे देना। आपकी पीपीटी की बड़ी डिमांड है, वो ये वाली पीपीटी भी दे देना। उन लोगों ने बहुत लाइक किया है। एपिलेप्टिक एन्केफेलोपैथी वाज वेरी इंटरेस्टिंग। उसमें से वीडियो हटा लीजिएगा, वीडियो हटा के तब दे दीजिएगा, ठीक है? चलो ठीक है शर्मा जी,
पक्का सर, पक्का सर।